Okay, Dr. Jenya?
Yeah.
Can you hear me?
Yeah.
Sorry,
So your
sorry.
presentation is not a voice, or if you could, so you present yourself, or.
Okay. I wait. Okay.
Also, there is no voice.
Okay. I think
your voice is clear.
No. Okay.
Please, present yourself.
So I think the most important case is the central lateral lead stenosis with a foraminal stenosis or double crush syndrome. So I think that this case is very important with the decompression without a fusion surgery. Therefore, I think that the four factors is very important pre-operative consideration. So first is disc height, and second is segmental lordotic angle, and third is degenerative lumbar scoliosis, and medial facet joint hypertrophy. Disc height is the patient disc height is low or disc height is high. I think that the probability of instability is high, and the patient disc height is high. So I think that a best case for the simple decompression is the patient's disc height is small. And some authors said that it's the disc height ratio. So standing X-ray disc height, and on CT scan the height is the ratio is over 1.8 over. So it is a good case for just a simple decompression, not fusion surgery. And segmental lordosis of lumbar spine is also predictive of instability. So study then the possibility of instability is high when it exceeds 70.4 degree in standing position and exceeds 24 degree in extension. In addition, if the sum of the segmental angle of L23 and L34 exceeds 5 degree, decompression should be avoided as the patient is highly likely to progress to degenerative lumbar scoliosis. The possibility of progression of lumbar scoliosis is also high when the lumbar cuff angle exceeds 20 degree and disc wedging over 3 degree. Even when central and foraminal and extraforaminal lesion occurs simultaneously in same segment, it is also important whether the problem is caused by bone or disc. The facet joint hypertrophy and bony foraminal extraforaminal stenosis is good indication for simple decompress because of low instability. For the past 2 years, I have often met elderly patients who need a fusion visiting my clinic, and they always said that they didn't want to do fusion surgery. So, doctor, is it okay for me to have a surgery at this age? So please let me know another way. So even if you refer to other factors, in practice, there are many times when different treatments are needed for each patient. So the most difficult case was the treatment of spondylolisthesis patient with almost no disc height and no dynamic instability. So this is the case. The patient is 71 years female, right-sided stomach pain, and the gait disturbance that lasted for more than 20 years. The X-ray shows almost grade 2 spondylolytic spondylolisthesis on L5S1. Instability was not severe. This space was very narrow. Shows the MRI shows the severe stenosis from foramen to bilateral lesion with disc protrusion on L5S1 right side. So my choice was the first final approach on L5S1 right side from foramen to bilateral lesion. So this is the operation video. First foraminal ligament was removed. And this is the L5 nerve root, dorsal root ganglion. And this is the L5 pedicle area and disc space. And this cactomy was done with Carrison punch. And the vertebrectomy or pediculectomy was done with a high-speed burr or osteotome. And I usually use 3 millimeter high-speed drill with a root retractor. And this is the sacral ala area, sacral ala decompression. So the ala decompression and lower body vertebrectomy was done with the osteotome. And here is the foraminal disc. The foraminal disc was resected with a Carrison punch. And we can see the extraforaminal lesion. The L5 nerve root appeared to compress the far lateral lesion. The far lateral lesion decompression was done. And this is the raw body of the raw end plate of the L5 vertebra. And finally, the sacral decompression and additional discectomy was done with the Carrison punch. So sometimes the operation field is enough, but when the patient starts working, sometimes patients said that they pain same before surgery. So I prefer to enough the space foraminal decompression than operation field. So finally, the sacral ala decompressed with the osteotome. Far lateral decompression. And finally, we can see the L5 nerve root very clearly moved. The post-operation X-ray shows there is no severe or aggravation of slippage on post-operative 14 days. These are MRI before and after surgery. It can be confirmed that the compression is sufficiently done from foramen to far lateral lesion. Okay. Then CT scan, the pediculectomy and the lower vertebrectomy area can be confirmed with this CT scan. And now 5 months after the operation, and the patient is doing well without any major discomfort. Summarizing the parameters through literature and my presentation, I think the best indication of simple decompression post-spondylolisthesis is the first an ipsilateral pathology and disc space and non-severe degenerative lumbar scoliosis, and finally the inactive patient over 70 years. So thank you for your attention.
Thank you for Professor Angawina.
I'm sorry. My presentation combined with the voice recording and my presentation, but it's not working
No,
good.
no. You're very clear. Very clear. Perfect. Okay. Change to the moderator, Dr. Shibayama.
Hello, I am Dr. Shibayama. So I will chair next two posters. The third presentation is Dr. Park Man-kyu from Good Moonhwa Hospital, Busan. So Dr. Park, could you start?
Thank you for a great introduction. Can you hear my voice?
Yes, yes.
Okay, I'm going to share my presentation. Can you see my presentation file?
Yes, yes.
Okay, I'm gonna start. Okay, good afternoon. My name is Man-kyu Park, working